Sure. Since this is the Yule's first time to join in, I can provide the introduction that I've provided, several times, but I think it's fine. And then I'll say what we're doing currently, the sort of the most active thing that we're doing. Can you all see that? Basically, Kim and I started this about 3 years ago now it was actually 2.5 years ago at the last Banff meeting in Pittsburgh in 2019. And, this is a Banff Digital Pathology Working Group. We've had a lot of people join, and I'll go through. Obviously, we appreciate participation of everyone. Right now, we're working on a paper. Let me jump to just sort of a slide that kind of puts forth our major goals. So, the top row, we kind of, we have a paper that I can show you the reference in a little bit, but that has a longer table in there that kind of lays out our goals. And it was kind of like over encompassing, and it's maybe too comprehensive. So what we have now is we're trying to sort of refine our goals and hone them down and make them more focused. And so really the first row is what is our major focus of this group. So the biggest thing that we've been working on is an image bank for AI and machine learning. And we want to kind of have something that, is available for the community to upload images, to share images, and also, test algorithms. And actually June Kong, who's on here, we've set up a nice one. He's set up a nice one and given us space on there. We have some test images on there, basically. Obviously we want to expand that further. He and I have done algorithm work mainly in the liver. But there are algorithms on there, but we want to have more algorithms in the future. Another thing to do is, so that's the biggest thing that we've been trying to do. And the ultimate answer to that will probably be that we have multiple image banks, and I can probably talk to, or at least show you some names of other people who presented, and all the names too. And I think I mentioned this when I met with you a couple of weeks ago. The other thing is algorithm validation, and also algorithms for the Banff classification, and also algorithms targeted towards certain Banff parameters. So the reason why this is different is the algorithm validation is sort of like trying to come up with ways for us to validate algorithms amongst multiple institutions, if there are good algorithms out there. Eventually, we'd like to have algorithms that can actually do a Banff classification, can actually essentially automatically do a Banff score on a biopsy. And then the other thing is Banff parameter algorithms. So algorithms targeted towards certain Banff parameters, such as fibrosis or inflammation. June's worked a lot on steatosis in the liver. He's working on fibrosis in the liver too. So algorithms that are targeted toward those things. And they may or may not use artificial intelligence. The other things that are on the lower sort of rows here are a little bit overlapping with other Banff groups. So, they're lower down on our priority list, but obviously computing and AI and machine learning and nanotechnology we had in there, that probably needs to be split off a little bit too, because, we wanted, our view of digital pathology is very overreaching or sort of broad. I know a lot of people define digital pathology
sort of a connection piece.
Yes. So, we obviously will include some of the things, we want to standardize practices. I believe Banff kind of has a working group that does this too. We want to decrease inter-observer variability. Again, that kind of fits into the algorithms. And also Banff has some other working groups that touch on this too. So we don't want to overlap with other groups. We would eventually do want to collaborate with other groups, and we kind of are doing that already. And then, classification using integrative approaches, that's sort of broad, and but it was one of our goals. So, and then precision diagnostics and molecular, and even therapeutics, natural language processing. Other groups have touched on this, and so we, can do this too. And then archetypes validated across multiple institutions, and this can include like molecular classifiers and such. And there is a molecular group too. So again, that touches on other groups. So the main thing that we want to talk about are these sort of top goals here. And I think this is like the third version of refining our original paper sort of table. But I think, obviously, as we talk through this in the working groups, we come up with more and more ways of looking at this. So anybody else want to comment on that, or any questions?
So I guess as a high level process question, when your working group identifies a solution or candidate solution or plan to develop a solution, how do you promulgate that back up to the larger Banff group? Do you just do it and then make a publication, or does this get adjudicated by the larger group in terms of it fitting into the grand scheme of things for the effort? And then when you have these projects, do you also in parallel come up with a plan for their clinical deployment? Because one of the challenges, with anything AI and machine learning is there's many publications, but far fewer examples of their having been successfully deployed in an actual clinical setting. That seems to be the final activation energy that we haven't quite reduced to a formula yet. So I'm just wondering how you promote things from being, academic, investigational, to being out there in the wild.
So I can speak a little bit about that in the specific ecosystem of Banff, that there are two sets of algorithms that already have regulatory approval and that sort of thing. So one is Alex Lupi of the Xbox, and he's fairly well-known researcher. So in kidney, he is the person who has the algorithms that are farthest along in terms of their acceptance by other bodies. But we consider it very healthy to have competing algorithms, not to just get stuck with one. Or so it seems like almost every Banff working group is working on AI algorithms, rather than saying no, shut that down, you can't do that. I think that let 1,000 flowers bloom. The only problem with that is it's Mao Zedong who said that. He slaughtered a bunch of nice sounding quotes, but it led to terrible things. But that's not going to happen here. This is going to lead to good things, I think. So it's a kind of very open system that we have, where we allow working groups a lot of individual freedom, but we don't want to confuse the public out there. Finally, we're going to need to pick something to kind of promote to the world, and yeah. So I know that sounds vague, but it is the sort of high-level decision-making of Banff as it currently sits. So, yeah.
That's helpful. So presumably then when these algorithms get developed and validated, there is the intent to generalize them, right? To have them be available and be implemented clinically?
Yes. And it is also the intent to not get ahead of ourselves. If we're at a point where AI is human decision making, we're not going to cede all authority to the machines before they're ready. So that's the other part of it. Just as Brad says, we'll be able to automatically calculate Banff scores. Now, those scores may be wrong or may be too simplistic, or the machines are making obvious errors. And so we expect that there would be that sort of transition, rather than as they're doing it's perfect and the humans out of the loop. We don't think that's going to occur for a while, because luckily transplantation is very complicated, and it's sort of like nature itself. Yeah.
I completely agree. You essentially, the metaphor is you want to keep an adult in the room, because the AI, as much as you've tried training, it really doesn't know what it's looking at. It's just a tool. I completely concur. It crosses my mind, and as full disclosure, is certainly Brad knows, I'm not a nephrologist, although as of the last 5 years, I've been working with, or a nepropathologist, been working with many with the Kidney Precision Medicine Project, one of whom is Zoltan Leszek. And just as an interesting side project, but I think there's overlaps with your group, we've come up with a little provisional pipeline. It doesn't do all the Banff, but it exquisitely identifies foci, even very, very small foci of tubulitis. And that, I'm told by Zoltan, that's useful. So, and we've just come up with a new version of the software that does it even better. So if you had, for example, a screening tool that could pre-screen your biopsies and create a gallery of all the tubulitis, would that help in scoring?
Yeah, that would be awesome. And I mean, you have a great question. I mean, like, we really haven't thought about that enough, is how to get these algorithms to the community, how to validate them. But that would be awesome, a tubulitis one. And we have had we did do one working group on fibrosis a while back. I helped with that, and we had we used a commercial algorithm just with a perio for positive pixel counting for fibrosis. But tubulitis is even a harder thing, obviously, to do, and we didn't have the algorithm that we did. We just said, hey, use this commercial algorithm if you want to. But a tubulitis would be an awesome thing. But we do need to talk more about how, to get these algorithms to the community. So your question is great.
That's the hardest part. I mean, it's one thing to make an algorithm that works, and that's hard enough. It can be done, but then how do you generalize it? And I'm certainly not claiming to have an answer, but what I've found, for example, on the CP side of things, we have a thiopurine analog test called Thiomon, which is entirely based. It's in silico. It takes a CBC and patient's gender, age, weight, and a comprehensive chemistry, and generates a 6MT calculation score for level of immunosuppression, which is better than the molecular-based test by extracting high dimensional data from these 29 indices from the CBC and comprehensive chemistry. My point being, we've had this running now for 12 years, and one of the very first AI-based tests. Wow. And yet I've not been able to figure out how to take this AI pipeline and deploy it anywhere else. This is a very hard problem, because LISs themselves are not standardized. And if you build on that concept of no standardization, if the LISs themselves are not standardized, it so follows that putting an AI pipeline on an AIS, on an AI system, on a LIS is not standardized. And we found that. We've tried doing this in New Zealand, in Australia, in Israel, and so far the only thing we've got that has worked is standing up a website where other labs can log in, use the deployment of our tool in its web form locally, and then get the results back. But that means that the AI actually has not been ported, right? It's living in situ where it was originally developed. And I really hope that's not the final model we come upon, because it'd be very difficult for any one site to be the steward of an AI algorithm for the world at large. But by the same token, then the challenge, if you implement it in a widespread fashion, when, let's say, one of the core groups that develops an AI updates it, how do you disseminate the better updated version to all of the disciples that use it? I don't have an answer for that, but there's a number of operational questions that don't have to do anything with the AI itself. There's, logistics of disseminating knowledge, because you're not disseminating knowledge like a paper, you're disseminating programs that have to interact with target LISs that are architecturally diverse and often very, very different, because we don't have standards. So I don't have answers for these things, but these are the kinds of things that your group potentially should wrestle with, because what I sense is in the very near future,
Sure.
you're going to be on the vanguard, way ahead of cancer. Cancer is way off in the distance. What I've seen with KPMP, medical kidney, chronic kidney disease, acute kidney injury is going to be on the absolute vanguard of applying AI to create added diagnostic information. And you're going to have a good problem. You're going to have really good AI, better than the cancer world. How do you deploy it? So that's something to start thinking about now, because I think kidney is going to lead the way in AI, even beyond radiology. Radiology has a huge problem.
Yeah.
It's at the mesoscale anatomically, which means you have like one of each structure. You have a pancreas, you have a spleen, you have two kidneys, and you have mesoscale structures. Yes, they're looking at textures, but the real textures we know is histology, right? The diagnosis is not going to come from a radiographic image, even if it's high resolution. It's going to come from us. The combination of the histology and all the molecular, which now can be superimposed spatially on the histology, which is information overload. I can show a couple slides of that. So we're about to be drowning in information. And I don't think we have as a specialty a solution for, once we have these AI pipelines that work, and I predict they will work, how do we deploy them? And so in many ways, your group has the mantle for doing this, because you're probably going to be one of the first consortial groups kicking out a succession of successful AI pipelines, right? So it's not enough to just generate a pipeline.
Yeah.
That's important, but you've got to disseminate it. That's a hard problem.
That's a great point.
Yeah, and the industry side also is not easy. There tend to be too few players. We become dependent on too few companies, and that creates all sorts of biases.
That's a problem.
So,
and we don't have standards.
Lynn has had her hand up for a long time.
Yeah, and look, I'm not driving anymore, so you don't have to worry. I was going to say along those lines,
Okay.
thinking about like tubulitis. I mean, now, even if we get something, if we make the mistake, like I do sometimes, of getting like a CD3 immunostain on a transplant, if I want to see, are those inflammatory cells in that artery, in the thickened intima or something. Sometimes I'll get a CD3 stain, and all of a sudden there's inflammation, that kind of reveals itself that isn't that apparent just on your regular old H&E, just your regular stains. You kind of disregard it. So thinking about, like, we're going to have even if we just find all the tubulitis, that's kind of a problem, because we'll kind of disregard like a little bit of tubulitis, but like one tubule with one cell. But if you have, my point is that,
to find all of it though, just to
well,
know where it is.
Well, it is what it is. I mean, maybe it's there, maybe it's protection, maybe it's inflammation, information related to an infection, maybe it's educational process on behalf of the immune system, maybe the regulatory cells, I don't know. But the point is, we're going to reveal much more about the graft. And I think, with the current definitions, Banff definitions, they're really going to have to be re-examined. We'll have to come up with a new definition of rejection, I think, because it's like everything's going to be rejection, essentially. We were thinking about this a little bit a few years ago with electron microscopy and using electron microscopy to give a different kind of CG score for transplant glomerulopathy. So anyway, my point is that we're going to have to come up with a way to evaluate outcomes and not just say, well, now this using a new tool, how do we fit it back into the existing Banff classification? Like, oh, we'll find tubulitis and we'll get a Banff score. I suspect that automatic, or automated Banff score is going to be different from, the human generated Banff score. So I think we need to have think about how to generate, outcomes data. And actually there was that paper looking at that was published, I think in January of 2021 from France, looking at different capillaritis scores with the different years of Banff scoring, or with different Banff definitions, if it would be, suspicious for ABMR or no ABMR. And then they had a nice, graph that showed with the different, the same set of biopsies not scored, I guess the scores are always the same, but the different, the same set of biopsies, looking at the different definitions through the years of Banff and how many would switch categories. So we'll need to do this, have a set like what they had. We could use their set, I'm sure. That was just for antibody mediated rejection definitions, but we should have kind of a set of biopsies at different institutions, I think, to try to test them, because we're going to be identifying a lot more, even just with our existing definitions.
Yeah, but those biopsies curated with exquisitely careful outcomes, because as you described, really the goal would be, especially now that you have multidimensional data, to take the outcomes and engineer back to all the data have, not just the histology, but lab findings, electron microscopy, whatnot. And because this data lives in a high dimensional space that is cognitively not approachable to people, to humans, without computational support, we may find in this high dimensional space reproducible signatures that correlate statistically very well with outcomes disease or classification of disease that, as you said, end up having maybe some similarities to our human-derived Banff score, but otherwise than that are fundamentally different. And so I wouldn't be surprised if by doing this process, you end up with a computational set of algorithms that correlates the outcome to this high-dimensional data set. And because if the goal is really predicting in prognosis and therapy selection, you're going to end up using that algorithm as opposed to the contemporary Banff, right? It'll be the Banff 2.0. And there's no reason at all it has to be similar. Maybe there'll be probably some parts of it similar, but I would expect that there be findings that are completely novel compared to what you're doing now that live in this high dimensional space that you can't even do without computational support.
Yeah, and
if you think about it, yeah.
Oh, go ahead.
Sorry, what I was going to say is from the beginning, the intention had been for Banff to be like continuous variables, not 1 to 4 plus or anything. I mean, that doesn't make any sense in a real, biological world. So the closer we get to those, continuous parameters, the better whatever we're looking at And the fact that we're so far from that now doesn't mean that we will not get there. We will get there, where we'll be using machine generated continuous parameters for everything. There won't be any 0 to 4 plus. It just doesn't make sense in the future.
No,
I don't know if that's the future in 5 years, 10 years.
maybe even less. And of course, many of our statistical models do much better with continuous variables than discrete variables. Plus, if you look at the kappa statistic, well, all kappa, inter-observer variability, and you ask pathologists to generate a number between 0 and 100, for example, forget it, right? I mean, even 0 plus through 4 plus can have a very high kappa statistic. Not even on the same biopsy, but when you tape it off and just say, look at this field of view. So I think that really argues strongly for quantitative tools that not only provide you a continuous variable, but also reproducibility, which, I think pathologists, our methodology is great in labeling things, making the diagnosis, getting the right biologic entity, but then grading stuff in a continuous or near continuous scale, we have very high dispersion. And I don't think that's going to improve. And we shouldn't be apologetic for it. We can't count pixels. Maybe some savants can, but most people look at an image and can't tell you there's 219 toothpicks on the floor, like Rain Man. Some people can do that. And, look at a bone marrow and say it's 84% cellularity. And you do the AI and it's like 83%. But, you can gestalt it, plus minus 10 or 20% cellularity, for example. So I think you're spot on. We need to go to an era of quantitation, but in tandem with that, pull out all these high dimensional variables, which right now are inaccessible to us.
I agree. I was going to say also, we should have a focus on outcomes too. I mean, and we have all the historical data, how patients were treated, what was based on the, human diagnosis, if it's gall, borderline or whatever. But we have, I think we should keep the focus on not just what we surmise or feel like would be rejection, but actually do take the outcomes data and then come up with definitions of rejection. And I agree that the continuous variables are an issue too. We found that, we had looked at reproducibility of different Banff scores for antibody scores, and there is a lot of there was better agreement, for the scores that were close together, which would reflect, more agreement between CG1 and 2 than there would be between CG1 and 3, for example, as a score. And that reflects, really the need to have a continuous variable like that. But when we have a Banff definition to say, okay, well, this is the cutoff, it's rejection if it's like this, or it's not rejection like this. So, but that's, and at some point with a continuous variable, I think we'll have to decide what is rejection or whatever, and how are they going to be treated. But that's where we really should be focusing on the outcomes data, which I don't think the Banff has focused on at all before.
That's a good point.
Well, we began in 91 with, consensus generation, which was really cool back in 91, but is not going to cut it. In the future, you can get much closer to the truth by not dealing with, control, but saying, well, the machine can help us make this decision. What should the cutoff be? Let's just think of this, objectively, not based on the will of the people in the room, but what makes sense, and there will be an answer. It isn't like we won't know what to do. We'll clearly know what to do. And it may be a little scary that it's so clear, you know?
Well, I mean, we already have this paradigm in clinical pathology. There's not much controversy when somebody reports a sodium of 141. It is what it is. And I don't know that we'll hit a postmodern state where the
Right.
histology is so cut and dry, but clearly if there's reproducible high dimensional variables that are not just indicative of diagnosis, but of outcome trajectory, and also maybe selection, therapeutic selection, right? Which therapeutic agents this patient would be most responsive to. Those should live in a high dimensional space, because at the end of the day, we are fundamentally molecular, and the disease is molecular. It manifests phenotypically in histology, and the hypothesis being, in some cases, the histology, if properly analyzed in high dimensional space, is going to tell you something about the underlying genotype. And then at that point, I think the AP becomes much more quantitative, like CP, and we'll be comfortable with that. At the same token, I absolutely don't believe that histology is going to go away. A lot of people say this will all become computational. You won't need to look at the slide anymore. And what those people don't realize is the anatomic frame of reference is still incredibly important. Like for oncology, cancer, the surgeon wants to know if the cancer is at the margin, right? You're not going to answer that by sticking it in a test tube. You're gonna generate a section. It is or it isn't at the margin, until we hit some postmodern state where we're not doing surgery and just treating everything chemically. Well, then there's no surgical margin. But as long as there's an anatomic frame of reference, there'll be histology. So the only thing that's really going to change for pathologists, I think, is what we do. We're still going to use histology. It'll be digital, and our tools will change. We won't be just saying it's a diagnosis. We'll be saying much more quantitative things, like it has this particular molecular cluster and this particular clinical trajectory and this sensitivity to these therapeutic agents, which I think will be much more satisfying to inform clinicians of, the overall biologic potential of disease, as opposed to what we do now is we label stuff. So I totally agree. But
so Brad, the recording of today, I think, is very important, and we need to get it out there. So sending it to me in some easy way, and we'll get it put up on the website, because I think we're talking about really pivotal things here that will have a strong influence, not only on what this group does, but all of Banff and all of transplantation. We're saying that the pig to human transplant is changing everything in the transplant world. I think what we're talking about today is also changing everything, so let's get the recording out there so people can ponder and
Yeah,
it's exciting, the intellectual ferment that occurs in these meetings that you're organizing, Brad. That's what every human being wants in their lives, whether they realize it or not, So you're doing it.
Well, it's been a great discussion. Yeah. And I really am glad, each time we have different, we've had new people several times along the way. And we're glad to have Priya, Alexandra today, and as I mentioned, also June. And, if you all have any questions or anything to say, but we can definitely put this up. And it's been really, really great having you, because you've made us think of some things we haven't had before. There was just, does anyone have any comments before? I had a couple of comments on what I said we were going to cover today. Does anyone have any?
Well, if there's time, I just wanted to show just a couple of vignettes. I mean, we can do in much more depth of just the type of computational pipelines that are available now.
Awesome. Yeah, please.
Yeah.
In terms of, so this is a pulmonary biopsy for BOOP and a UIP, but the notion of what it does should be obvious. Let me see if I can share this little screen. Here it comes. Yep. So let me go to the original image first. So this is a patient with pretty severe pulmonary disease. And there are areas that are preserved and there are areas that have significant fibrosis. This is, of course, an H&E stain. So you can see that this is not a happy biopsy. It's actually a wedge. So we're used to looking at stains where they're either, general macroscopic areas like H&E where, general classes of the cells get labeled, the nuclei, of course, with the hematoxylin, the cytoplasm with the eosin, and then basement membrane collagen, also mostly with eosin. But it's not biological context. It's the chemistry. That's why we call it histochemistry. And then we have the more specific staining strategy of, a targeted antibody with immunohistochemistry. But what we really don't have is, at least not widely available yet, is a digital stain where the algorithm assesses every pixel and asks the question, what is this pixel in terms of its biologic potential, its context, and then assigns a color based on the biologic meaning, like this is a vessel, this is fibrosis, this is epithelial surface, this is normal alveolar wall, this is thickened alveolar wall. And we can perhaps in the future set a time to go through how these pipelines are built. But once you build a pipeline like this, you can take a whole slide image that has just normal H&E. And again, the colors will look a little bit unusual. So this has been converted now to every location is biological context. So the cyan is the normal alveolar walls, and then different gradations of fibrosis have different colors. And then of course the bronchioles have their own color as well. So it's not something pathologists are used to, but I think this is coming down the pike where we will have various palettes of digital stains where we can use the color to cue us in to a biological structure, so based on context, not just the histochemistry or going after one epitope, as immunohistochemistry can do. And because this is based on combinatorial logic in a high dimensional space. This image was generated from a 3,000 dimensional array that was then trained by a machine learning technique, which is really very mundane, which is k-means, where we just collapsed it down to a few classes. Each class then gets assigned a color. So, and this can be applied to kidney. And in fact, this is the same pipeline that I worked with Zoltan to do the tubulitis identifier, where the histology is left alone, and except where there's tubulitis, and then it lights up as an assigned color. So this perhaps, can whet your appetite. So you have some bronchioles here, for example, for the kind of digital stains that are now possible with computational assistance, where the color takes on an entirely different meaning than histochemistry. It takes on the meaning of biological meaning, context. What is going on in this area? And it's not just, collagen. It could be like severity of fibrosis. And really the sky is the limit based on how you want to train these pipelines. There's no limit to the number of pipelines you can generate in parallel and then have them available along with the pre-screened image. So, I can imagine a future sign-out case where you're looking at the slide going, oh, okay, this is what I think it is. And then you look at the biological context and you get the computer's assessment of what every location means. So anyway, not to take up any more time, but this is kind of a sign of, I think, things to come with computational assistance at actual sign-out. So intended for actual pathologist use.
Yeah,
Do you have your
and it
example?
challenges human limits because, like, there are human beings detect many more colors than many of us can. So for them, you could create something much richer because they can see manyfold more colors than.
That's right, and you can
normal
turn on and
people's.
off all those colors at will, so you can make a custom palette.
Yeah.
But so this is where the Banff group could really shine. This really screams for standards. Then the group could come up with color palettes, which presumably would be compatible with people with color impairments, that are for standard for each panel, just like radiology has come up with the standard windows, like the bone for CT and MR, the bone window, the soft tissue window, standard adjustments of Hounsfield units for attenuation. And in terms of interpreting tubulitis, the Banff group could put, this is the recommended color palette. So that way, any pathologist anywhere in the world looking at an AI image and a digital stain, who's used to looking at that stain will see the same presentation, just like now an H&E in North America is the same as an H&E in Europe, for the most part. We have progressive and regressive hematoxylins, but that's another story. But in general, I think there's a tremendous opportunity to lay the groundwork of standards before many vendors come out with their own implementation that are guaranteed to be at least initially different. So get ahead of it. So not just deploy the AI, but deploy the AI in a manner that's intended for clinical use, which means standard palette of colors, standard workflow, standard magnifications, standard assignment of features. Like if you're going to do the tubulitis, what are the other counter stains? Because they're not histochemical anymore, they're structural. Maybe you want to see healthy tubes in one color, injured or sclerotic tubes or atrophic tubes in another set of colors. That's for your specialty to come up with a standard approach. So a digitally stained slide in Alberta looks the same as it does in Caracas or something, worldwide.
So Dr. Balis, this is Dream calling from Georgia State. Unfortunately, you cannot see me because my camera is down. It's always down. So can I ask you a question about your results you just showed? I think this is very impressive results. I just want to ask you if you would be mind sharing some information about the way you prepare the training data to train the algorithm with, because presumably you have to sign, what I can imagine, you have to sign a label, class label to each pixel within an image neighborhood, and then have that neighborhood as one training data sample for your algorithm to learn from.
You're exactly right. So I have a tool that lets, so Brad's seen it. Again, there's not time to show the whole thing up. I'll show my screen so you can see the magic happening behind the scenes. It's this tool, which right now is running a pipeline, so I can't I don't want to stop it, but basically this tool allows me to classify things in the first level of k-means and then create basically classes of classes. So by the time I'm done, the algorithm really understands, because I've labeled it, what the different regions are biologically, and lets me assign a color to a region. So this pipeline is locked down right now in two, actually screen capture has the full model. That this is a GI one. See if I can bring this up.
I didn't realize that was a Yule time.
Yeah, thanks for joining.
Sorry, I'm late.
Thank you so much for joining. Yeah, Yul joined us today, so he's been showing us some great things, and we've had a great discussion. We plan to post it too.
Yeah.
Uh-oh, did we lose Yul? Are you there?
Stuck. Okay.
Oh, okay.
Can you still hear me?
Yeah, yes, we got you. Yeah, yeah.
So normally,
Yes.
when this is running, if the whole slide image is here, the first level k-means is here, the second level k-means is here. In this case, this is a lung biopsy I'm doing for someone. The normal alveoli have been labeled independently with this aqua color, and everything else has been labeled with different functions. So it's basically a way of converting any image at the pixel level into its biological context.
Thank you for showing us this amazing annotation and algorithm too. So I think it's a very, very, very impressive idea. So basically you just select a very limited number of pixels and assign their label, and then the k-means will learn the color feature or whatever, and then apply it to the remaining pixels for you to review, right? Then if you think it's okay.
Yeah, let me abort this run so I can show you the program actually running. Is my screen being shared right now or no?
It is.
Yes.
Mhm.
Yes.
Okay, let me save this just to get rid of it.
I tell you, if you're available in 2 weeks, we could also that kidney example you did was pretty amazing. And if we had time, we could go through that. I think this
Yeah,
group,
I think we need more of this for sure.
yeah,
So,
yeah.
and as soon as possible.
I'm happy to do that because right now Zoom is making it difficult for me to use this program. Oh, it moved. So let's see if I can load an image just to give you a quick sample of how I actually generate vectors.
I think in 4 weeks, Lynn has volunteered to do a talk on immunofluorescence. Is that still good, Lynn? Okay, that would be awesome. Yeah. But in 2 weeks, we don't actually have anything. So if you are available, then you'll also, I mean,
I'll be back from USCAP. I'm actually finishing a pretty large project for the KPMP project. So depending on,
Yeah.
time-wise, I should absolutely be available to do
sure.
that.
Well, you'll still get the
Cool.
invite and but if it turns out you can't, that's fine too. We're very flexible. So thank you we're so glad you joined today.
Yep.
One of the things I was going to talk about is our paper, but we can do that in 2 weeks more too. But basically we're going to give each person who gives a talk to our group a paragraph in the paper or more if they want it. We'll figure out how to organize it. But, if you want to talk, then we'll, obviously we're glad to have you as part of our working group. And
That's great.
yeah.
And actually, I've loaded the tool, the earlier version. We have to get you the new version, Laura, on Laura's machine, so she can speak to the fact that it's designed for a pathologist to use directly. You don't have to be an imaging scientist to create these segmented, annotated regions. And the project we have going with KPMP right now is something as mundane as just classifying tubules. So it's definitely aligned with the nephrology subspecialty. Do you have any comments you want to make, Laura, on its usability?
No, I think would be very interesting, even in the transplant setting. If, for example, if you think how we did for the tubules, right? So we segmented tubules, we classified tubules based on Viper characteristics, but then, and we're doing that on CKD and AKI, but that obviously applies to other diseases. And in transplant, I'm thinking about antibody-mediated rejection, for example, or when you have a delayed graft function. You can pick up some signatures from the tubules that can predict the delay. So it's a delay that is resolving, it's the delay that may not resolve, etc. So definitely there are a lot of application in transplant pathology.
That's really awesome too. I mean, that sounds great.
Brad, I just want to tell you that I am terribly jealous of you, terribly, because I was trying to get Anand to come to Duke, but he's coming to Emory.
I know, yeah, that was amazing. I was really surprised to hear that guy's coming. Yeah.
So he was supposed to come here, and then they contacted the person who said, "Hold on, because I'm moving to Emory, and I give you this and that," and so there he goes.
Well, I know
Cool.
both you and you have worked with him a lot. Both
I'm
of you
working,
worked
yes. So there will be opportunities for collaboration.
Well, I hope maybe I want to meet with him when he comes, and also maybe I could even, it'd be hard, but maybe I could even get him to talk to this group and, think about how he could help us too. And, because we're going to have multiple ways of solving.
May have more time than Anand to talk to this group.
Yeah. And
he has a few good talks about tool development.
Oh, cool. Who is that again?
You will be more successful inviting Andrew.
Okay. Yeah, that sounds great. Yeah. Well, I had a little message that I was going to run by the group, but I think I'll just run it by you, Kim, as far as I'm going to send out to the people who are going to contribute paragraphs to the paper. We have an outline that I've already run over, basically reviewed. I'll also put some things on Slack, and we'll put this video up, and, you know, I think there's a Renal Pathology Society board meeting right after this, so I think we'll have to end this shortly, but does anybody have any final comments?
Well, it's a great meeting, and thanks everybody who came, and luckily it hasn't been the only great meeting. We've had a lot of great meetings of the mind.
Hey, I have a comment.
But we'll put this.
Sorry.
Yeah. Yeah.
Sorry, I thought you were done. What about, so I said I would talk about our IF slide scanner evaluation process and everything in 4 weeks, I guess. But what about what would be ready for digital pathology now is electron microscopy. Have you looked at that at all? Like,
So the algorithm we have,
and, you know,
it does work on black and white. It does work on black and white. So it takes biological context and it basically colorizes EM based on biological meaning of structures, but you have to train for it. You need a separate model.
Because that something should also be on our agenda at some point.
Yeah.
Like, for example, you could find podocytes or lack of podocytes. I guess we still use, of course, expansion microscopy might be changing that. But I guess many places still use EM to confirm minimal change in disease, for example.
Yes.
Well, yeah, definitely. But in the transplant setting, you know, we look for reactive endothelial cells. We look for, earlier or more active changes or more chronic changes. And it's the kind of thing that's harder for a pathologist to estimate maybe, but would be easier with computer assistance, I guess.
So
but it might help, categorize people for clinical trials for antibody-mediated rejection.
That's good.
So we can try it. I mean, I'm not a nepropathologist, so I don't know the contemporary questions, but what I do know, I have a hammer and it's looking for nails. So essentially, if you have difficult types of media images in general, I mean, it works on CT and MR as well, it will help classify surface area. So as long as there's a computational reproducible signature, and presumably there is, because we can see it as pathologists, right? So if we can see it, then the algorithm can see it. And sometimes the algorithm sees more than we see. That's the good news.
Awesome. Well,
Great.
That's a great
Okay,
thing.
well, fantastic meeting. And Ulysses, we'd love you to come back in 2 weeks. Yep. So.
Yep, I'll be at USCAP if any of you are there. Look forward to.
I'll be there.
All right.
In person.
Excellent.
There.
Great.
Great.
Okay, thank you, everybody.
Thanks,
Thank you all so
everyone.
much. See
Thanks
you
for
in
the
2 weeks.
invitation.
Thank you. Take care.
Yeah.
Take care.
Thank you.